Now I'm going to present two abstracts about TAP real-world data in entecavir switch. Entecavir is one of the longest nucleotides for the treatment of chronic hepatitis B. One of the weaknesses of entecavir is potential viral resistance. TAP is a new tenofovir prodrug. It is absorbed in liver cells, thus allowing a small dose and less tenofovir exposure to kidneys, bones, and other organs. So in this study, with the title Increased Viral Suppression Rate in Real-World Chronic Hepatitis B Patient After Switch from Long-Term Entecavir Therapy to TAP. This is a multi-center study involved more than 18 sites in United States, Korea, Japan, and Taiwan. The leading author is Dr. Mindy Nguyen, and I had the honor to be a co-PI in this study. This is a multi-center study involved 425 patients who has been on entecavir for a long time. The average patient on entecavir treatment is about 6 years. And this patient was switched from entecavir to TAP. And you see in the baseline characteristic of this patient in this slide, the average age is 60 years old. Almost 100%, 90% of these patients are Asians. The HBV DNA suppression is 91.9%. Now, keep in mind, this patient has been on entecavir for a long time, but they have not achieved 100% complete viral suppression. The ALT is 90% normalization, ALT normalization about 90%. There's a number of the patients with comorbidities in this study. About 21% of the patient has diabetes, 14.8% have liver cirrhosis, and 27% patient has hypertension. These comorbidities increase the risk factor for chronic kidney disease. Now, if you look at the bar graph on the right side of the slide, showing that 92% of the patient on entecavir able to achieve complete viral suppression. When the patient switched to TAP at week 96, 97% of these patients were able to achieve complete viral suppression, which is 5% more. If you look at the lower corner of the slide, showing that how the distribution of chronic kidney disease when the patient was switched from entecavir to TAP. In the blue circle, showing that 11% of these patients has minimal stage 1 chronic kidney disease progressed to stage 2. And 8% of, in the middle circle, showing that 8% of those patients who has chronic kidney disease at stage 2 progresses to stage 3 and higher after they switch to TAP for 96 weeks. On the other hand, 18% of these patients with chronic kidney disease stage 2 improve their kidney function to stage 1. And on the right hand, the gray circle showing that 19% of those patients with CKD greater than stage 3 to 5 improve to stage 2. So the author conclusion of the study is complete viral suppression increased following switch from entecavir to TAP without significant changes in ALT or chronic kidney disease stage. In my opinion, the patient who has progression kidney disease from stage 1 to stage 2 or from stage 2 or 8% from stage 2 to stage 3 and 5 higher, it is everything probably due to aging. Keep in mind that when we age at older than age 40 and 50, our kidney function decreases with age, about 1 cc per year. So this is probably a reflection of aging process rather than the medication. The surprise finding in this study is that on those patients who were on entecavir were switched to TAP now have improved kidney function from stage 2 to stage 1 and from 3 and 5 to stage 2. One explanation maybe is that because TAP is probably is much more efficacious than entecavir, leading to the more viral suppression than entecavir, which in turn leading to less chronic inflammation and is such that improve the kidney function. The second abstract with the title is Sequential Therapy with TAP in patients with chronic HBV. This is also a multinational prospective study. The leading author is Dr. Ichi Ogawa, and I was also a co-PI in this study. The goal of this study is to evaluate the biologic, as well as renal outcome in real-world cohort patients who have been on different nucleosides such as entecavir, TDF, or adefovir, who are now switching to TAP. In this study, there's about 261 patients enrolled in the study. There are two cohorts. One group, about 199 patients, were on entecavir treatment before switching to TAP. And there's another cohort of 62 patients on TDF or adefovir were switching to TAP. In the entecavir cohort, the undetectable HBV DNA was 94%. On the TDF cohort, the undetectable HBV DNA was 100%. Now, if you look at the right side of the slide, and you see very similar to the previous abstract, the entecavir was 94% complete virological response, increased to 97% after the patient was switched to TAP. And for the patient in the cohort group of TDF and adefovir, the complete virological response is already 100%, so they cannot be better than 100%. However, we should notice that there is no decrease in the complete virological response. Now, if you look at the lower portion of the slide, showing that there is no change in renal eGFR on the patient who on entecavir, TDF, or adefovir were switching to TAP. In fact, there is slightly improvement of the eGFR after the patient was switched to TAP. The conclusion of the author from the study is switch from either entecavir, TDF, or adefovir therapy to TAP appears safe and effective with continued viral suppression. Age was the only factor significant associated with decrease in eGFR. As the study was done only 1 year so far, they also said that the longer-term follow-up will be required to determine TAP is sufficiently effective and safe after switch over. So what do these data mean to you and to me? I think these data are very much consistent with on the studies across the globe. And this is the same result that I see in my practice treating thousands of the patients chronic hepatitis B. So one point I'd like to make is that it is very surprising to me to see that the patient who were from entecavir switch to TAP actually has better renal function, and that is a surprising finding which I did not expect us pay attention to in my practice. The question, what are the clinical and patient factors to consider for switching antiviral treatment in chronic hepatitis B patient? In my practice, if the patient is on entecavir for 1 year or longest 2 years, if they do not achieve negative HBV DNA, I will switch the patient. The reason is if the patient has persistent positive HBV DNA after 1 or 2 years on entecavir, there is a good chance the patient may develop resistance with time. I think we try to avoid that problem. If the patient, now second thing, the patient on entecavir, to take entecavir, the recommendation that had to take the medication without food. I mean, 2 hours before eating or 2 hours after eating, that may be a problem for some patient, especially a senior patient who may not keep an empty stomach the 2 hours for medication. Which patient would I switch? If the patient is on tenofovir, if they are at 60 or older, or they have comorbidities such as hypertension, diabetes, I would likely to switch the patient from TDF to TAP because I try to avoid the renal side effects and also the bone side effects. Question antiviral therapy to switch to, once again, we talk about the entecavir to switch to TAP, and the patient who's on TDF need to be switched. I would like to also bring out the medication andefovir. I haven't had any patient on andefovir for a long time. In fact, I have switched every patient who has been on andefovir to either TDF or TAP. The reason because andefovir is a weak medication. It does have a high risk resistance. It does have a significant renal side effect. And if the patient is on andefovir, I would not switch the patient to entecavir because I'm worried about the concern about the risk of resistance if the patient go from entecavir to entecavir. So it's much safer and better to switch the patient to either to TDF or TAP. I hope you enjoy and learn something from this abstract to apply to your clinical practice and to take care of your patients.